Hello and welcome to our next antimicrobial review. This discussion is more of an alphabet soup of antimicrobials compared to Antimicrobials 1, where we just discussed the beta-lactam class. In this review, we'll discuss several different agents that you'll see used in the primary care setting as well as the inpatient setting, but focused on primary care. Things like the fluoroquinolones, tetracyclines, macrolides, sulfonamides, and some agents to treat MRSA. Our objectives for our discussion today are actually the same as the Antimicrobials 1 lecture, so making sure that you can describe the agent's spectrum of activity, as well as identifying practical clinical issues, including some high-level select drug interactions and adverse drug reactions for the agents that we will be discussing today. Again, as far as a disclaimer goes, this is the same as your first antimicrobials lecture. We won't cover every single organism and coverage pattern. It's important to know your local uses and local patterns for resistance as well. And the focus will be on the more commonly used agents within each class, and the stoplight coloring is really just an at-a-glance guidance, but make sure to take your patient specifics and your local antibiograms into consideration when selecting agents. This is included again for you just as a reference point and a reminder that we won't be talking about the microbiology of all of these infections, so please refer to pertinent infectious diseases guidelines such as those from the Infectious Diseases Society of America or from the CDC, and we'll speak about some of those in an upcoming lecture on disease states. Okay, so we're going to start with one of the most widely overused and misused classes of antibiotics, and that being the fluoroquinolones. When the fluoroquinolones came to market, they provided us with one of the first truly good gram-negative spectrums of oral agents, and that is not necessarily as robustly the case anymore due to the development of resistance. But fluoroquinolones essentially bind to a bacterial enzyme and block something called the topoisomerase. And what that does is prevent relaxation of the organism's supercoiled DNA. And that's required for normal bacterial transcription. So by blocking that, the fluoroquinolone prevents normal bacterial transcription and thus renders that organism ineffective. In terms of the spectrum, we tend to break these up into thinking about them two different ways. We think of ciprofloxacin sort of as its own entity, and then levofloxacin and moxifloxacin, and there's also a couple of other agents that are lesser used that I didn't include on this slide, but we divide them into these two sort of silos, being the urinary fluoroquinolone coverage of ciprofloxacin and the respiratory fluoroquinolone coverage of levofloxacin and moxifloxacin. Now, to give it sort of a caveat, I think naming them that way or classifying them that way can be a little bit misleading because ciprofloxacin does actually penetrate to the lungs. So if we had an organism like a Pseudomonas that was susceptible to ciprofloxacin, we could use it to treat a pneumonia. The reason that Cipro is classified as a urinary agent, though, is because it lacks coverage against these more typical pneumonia or respiratory agent or pathogens. So most notably, it misses strep pneumoniae. So for that reason, we think of levofloxacin and moxifloxacin as agents that we would use to treat pneumonias, not necessarily, like I said, because of the lung penetration being better, because it's not, but the pathogen coverage that we would typically see for pneumonia is achieved with levofloxacin and moxifloxacin, but not empirically achieved with ciprofloxacin. So you'll see Cipro used often for UTIs and things of that nature where the Enterobacteriaceae are primary pathogens. Things like abdominal infections as well. Ciprofloxacin typically has adequate coverage. From a miss standpoint, you can see that Cipro does miss anaerobes as well as these listed here. And from a levofloxacin, moxifloxacin standpoint, you still have poor enterococcal coverage, and moxifloxacin does have anaerobic coverage. Sometimes you can see here, and it misses Pseudomonas. So that's essentially one of the pathogen gaps that makes moxifloxacin different from levofloxacin. Is Moxi is a very poor anti-pseudomonal agent, whereas levofloxacin, about 50% of the time you'll get an isolate that still has a quinolone sensitivity to it. In terms of some practical clinical issues with the fluoroquinolones, you can see that moxifloxacin should be avoided if you're treating a urinary tract infection. The reason for that is moxifloxacin does not achieve good urinary concentrations, so therefore it's not going to effectively treat a urinary pathogen. If you do need to use a fluoroquinolone to treat a UTI, ciprofloxacin or levofloxacin would be your choices. In terms of notable adverse drug reactions, the quinolones are somewhat of a muddy class. There's a lot of adverse drug reactions that we do see in patients who are on fluoroquinolones, and our patients, such as our elderly patients, patients on higher doses, patients with underlying disease states, may be more at risk. So we're going to cover some of these more commonly seen adverse drug reactions. The quinolones can cause the stereotypical GI upset, so a little bit of nausea, vomiting, diarrhea. These can be taken with food. We just need to avoid divalent cations, calcium, magnesium, because it can chelate the drug in the gut and prevent absorption. We can also see an interstitial nephritis develop, hyper and hypoglycemia. This is especially relevant in your diabetic patients. So while all of the quinolones can cause this, moxifloxacin and levofloxacin tend to be worse offenders compared to ciprofloxacin. If you do have a diabetic patient that you start on a fluoroquinolone, I'd recommend that they potentially check their blood sugars a little bit more often. Obviously, infection itself can have an impact on blood sugar. They may need to be in touch with the office a little more frequently in order to have guidance for dose adjusting insulin, etc. Another class effect of the fluoroquinolones, again with moxifloxacin and levofloxacin being slightly worse offenders, is that of QT interval prolongation. I've seen this quite frequently in my practice, especially in patients who are on concomitant agents that can prolong the QT, so some of your antiarrhythmics, for example. We need to use these with extreme caution. And in the outpatient setting, I would argue that if you have someone on a QT prolonging agents, things like dofetilide, for example, for treating arrhythmias, it may be prudent to check with the electrophysiologist in terms of a management plan on the outpatient side and what you would want to be doing in order to make sure that the patient isn't at risk. A big one that I think worries patients when they read it in the prescribing material that they're given when they receive their prescription is that of tendinitis or tendon rupture. We do see this, and I have seen it. I have seen patients get admitted with this adverse drug reaction, but when we see it, it tends to be most commonly with the high fluoroquinolone doses, so higher doses like 750 milligrams of levofloxacin for a more prolonged treatment course. And then for those people who are on concomitant oral steroids, so maybe your COPD patients, for example, and then our elderly patients are more at risk. In addition, patients who have renal insufficiency that may not be adequately renally dose adjusted are also at higher risk. So when those Swiss cheese holes align, for example, you have an elderly COPD patient with some renal insufficiency on a high dose of fluoroquinolone, that would trigger me to be aggressively monitoring for tendinitis. So they should be referred to be very aware of any new muscle aches, pains, joint aches, pains, and things of that nature. I alluded to the chelation in the gut on the previous slide, but essentially to emphasize it again, patients need to separate administration of their fluoroquinolone agent from anything with a divalent cation. So, like I mentioned, calcium, magnesium, antacids, things of that nature, iron supplements, multivitamins that might have multiple divalent cations in them. If they don't, separate them by at least a couple hours, and we usually say 2 hours before or 4 hours after the fluoroquinolone administration. Essentially, it can significantly decrease absorption of the fluoroquinolone, and if we have lower levels of drug circulating, it's going to be less effective to treat the infection and actually potentially lead to development of resistance. All of these agents can cause an increased INR in your patients on warfarin, so making sure to have an appropriate monitoring plan, not only when these agents are started, but when they are discontinued. And like I mentioned earlier, the ADR of QT prolongation is more of an additive effect, especially when patients are on other agents that can prolong the QT interval. Okay, we're going to shift now from the fluoroquinolones to our next class of antimicrobials, and that's the tetracyclines. So again, the 101 level version of how tetracyclines work is that they're transported inside the cell, the bacterial cell, and they bind to a 30S subunit of the bacterial ribosome. And what this does is causes an interference with bacterial RNA production and prevents additional amino acids from being added to the growing peptide. So essentially, it stops bacterial growth that way. You'll see that I've separated these out again. We have the tetracyclines that are most commonly used on the top, doxycycline and minocycline, and we have our glycylcycline agent, which is sort of a structural cousin to the tetracyclines, and that's tigecycline. You'll notice on here missing is actually tetracycline. Tetracycline is very rarely used in clinical practice, and if it is, it's almost always for skin or acne type indications and not for a therapeutic infectious disease indication, so I chose to leave that one off. But in terms of doxycycline and minocycline, our top two agents, they have good atypical coverage. So from that perspective, they are a alternative agent in something like community-acquired pneumonia, mild community-acquired pneumonia being treated in the outpatient setting because of their good coverage of atypicals. Borrelia burgdorferi, or the causative pathogen of Lyme disease, you'll note under there, these are doxycycline, especially as a treatment of choice. And you'll see that neither of these have anaerobic coverage. They're poor against gram-negative rods, and they're poor against enterococci. One of the things that I have seen these used for with increasing frequency over the last years is an oral agent for treating MRSA. So especially community-associated MRSA patterns, so those small little abscesses and otherwise healthy folks who come to their physician or provider's office or emergency department to get that abscess looked at. Oftentimes those community folks who have no exposure to healthcare will have a much friendlier MRSA in terms of having oral agents available to treat it. And doxycycline and minocycline are often used for that indication. In terms of tigecycline, our glycylcycline, this one's only available IV, so you'll typically see it used in the inpatient setting only. And actually, with some of the more recent black box warnings that have come out, it really has fallen to a second and probably third line agent for most indications. Where it niches in is for patients who have multiple antibiotic allergies, as very few patients truly have a tetracycline class or tigecycline allergy. You can see that tigecycline, if we do use it, has a good line of gram-positive and atypical coverage, does not cover Pseudomonas, Proteus, or Providentia, so we lose a bit of gram-negative coverage that way. The tetracyclines do have a few clinical considerations that you should know about. Like the fluoroquinolones, the absorption of these agents are inhibited by divalent cations. Doxycycline to a lesser extent, but still in an ideal world, we have patients separate them out. These also aren't well absorbed at a high gastric pH. So for patients on acid suppression, they may see less absorption. I think that when you can, if you can have patients who are taking things like H2 receptor antagonists, so things like ranitidine, if we can separate those doses out by the longest interval possible. The tetracyclines do have a significant incidence of GI side effects, most notably diarrhea. Patients can expect to experience that. And we recommend that they aren't used in children under 8 years old. There's a risk for tooth enamel hypoplasia in the developing permanent teeth, and therefore the children would have resultant teeth staining. So unless the risk outweighs or the benefit outweighs the risk, these typically aren't used in younger children. This is seen to a lesser extent with the quote, newer tetracyclines like doxycycline and minocycline as compared to tetracycline itself. But I'd say that most providers do still use that clinical rule of thumb of 8 years of age, unless you're consulting with a pediatric infectious disease specialist and they really decide that it's the only thing for that patient. Likewise, it can cause some temporary tissue hyperpigmentation, notably around the fingernails. You can do a quick search on the internet and see some example photos of tissue hyperpigmentation from tetracyclines. And this is a class that can cause photosensitivity or increased sun sensitivity, probably one of the worst offenders in terms of this, of the antibiotics. So patients should be taught to cover up. They can use sunscreen. I just rather tell them while they're on these agents, wear long sleeves, stay out of the sun, wear a hat, because sunscreen just isn't as effective. In terms of tigecycline, one thing about this drug and how it's distributed is somewhat unique. So tigecycline is very highly distributed into tissues, and it doesn't get good blood or serum concentrations. So for that reason, it seems kind of strange. You're giving an IV agent, but you don't get good blood concentrations. But I think that's a key point to recognize. We can't use this agent to treat bacteremias for that reason. Likewise, because it's so highly distributed into the tissues, it gets very low urinary concentrations. So it's a drug of last resort for UTIs. And finally, I think we sometimes under-recognize the effects, the potential adverse effects of IV agents as well. And with tigecycline, despite the IV route, about a third of patients will still experience significant GI effects, nausea, diarrhea, vomiting. So it's important that if we do see that manifest, that we manage it appropriately. Unless you're using this to treat, for example, an intra-abdominal infection, then we also need to weigh whether that diarrhea or nausea is from worsening infection versus the drug itself. Shifting now to the macrolide class, you'll see 3 macrolides listed here. Clarithromycin and azithromycin are on their own line, and erythromycin set off on its own line. Erythromycin is really not used therapeutically to treat infections much anymore. It's got lots of side effects associated with it, more drug-drug interactions associated with it via cytochrome P450. And so for that reason, you really won't see much erythromycin used therapeutically. Use is primarily topical for acne type indications, or you may actually see it used as a kinetic agent, a GI kinetic agent in patients with gastroparesis. So it can actually be used to try to stimulate gastric motility. So we'll talk and focus primarily on azithromycin and clarithromycin. Again, azithromycin especially is widely prescribed, and I would argue overprescribed in the ambulatory care setting, especially with the indication of upper respiratory tract infections, most of which are actually viral. So I think that's something from an antimicrobial stewardship standpoint to keep in mind when using these agents. Because the Z-Pak route of prescribing azithromycin is so easy, or relatively easy for providers and patients, I think sometimes there still is a propensity to overprescribe that agent. You can see that clarithromycin and azithromycin have good coverage against some of the respiratory pathogens. Streptococcus pneumonia is variable in its coverage, and strep pyogenes as well. So not a good first-line drug when you're thinking of streptococci. And they also lack coverage against staph enterococci, as well as enterogram negatives or Enterobacteriaceae are not covered, and they don't have anaerobic coverage. In terms of how these work, basically these are ribosomal agents as well. So you can see it's a different subunit. It's a 50S subunit. And like our previous discussion on tetracyclines, essentially they inhibit bacterial protein synthesis. There are several notable drug interactions with the macrolides, and these are primarily based on cytochrome P450 issues. So with clarithromycin and erythromycin, they are 3A4 substrates, and so they also cause inhibition of 3A4 and 1A2. So any of your drugs that utilize those pathways, there's the potential for drug-drug interactions. Azithromycin is not a significant CYP3A4 inhibitor, so if you do have a patient on multiple CYP3A4 agents, this would be your safest choice to try to avoid that drug interaction potential. There are a few notable adverse drug reactions for this class. GI hypermotility, as I mentioned, erythromycin can be used therapeutically for this indication to try to stimulate gut motility, but as such, you'll notice that these drugs do oftentimes cause abdominal cramping and diarrhea for your patients. In terms of the cardiac side, again, you'll see that QT interval prolongation shows up here like it did with fluoroquinolone class. All of these agents have the potential to cause QT interval prolongation. The risk is especially high if there is a drug-drug interaction based on CYP450 and patients are taking concomitant QT prolongers with these agents. So again, it's one that you really have to decide that there are no other options that are less likely to prolong the QT. And then once you do that, it's establishing a monitoring plan for the patient, making sure that their potassium and magnesium levels are stable so that we don't have electrolyte issues, also potentially prolonging the QT interval. Shifting now to the folate antagonists, or what we more commonly refer to them as the sulfa drugs. The one that we'll talk about primarily is trimethoprim sulfamethoxazole, brand name Bactrim. Dapsone, pyrimethamine, and sulfadiazine are typically used under more specialty situations to treat infections. So I'm not going to focus our discussion on those. We'll focus on TMP sulfa. You can see that it's sometimes abbreviated as TMP SMX, TMP SMZ, so essentially the same thing. And the ratio of TMP to sulfamethoxazole is 1:5. And when we dose, and this is especially prudent when we're dosing on a milligram per kilo basis for the IV preparation, we dose based on the trimethoprim component. And you can see that there is the potential for error if you would dose based off of the wrong one. With electronic prescribing now, I think that is decently corrected, and there's a safety catch there to make sure that people are dosing based off the trimethoprim component. So to discuss the basic mechanism of action of this drug, it's based on a structural similarity to para-aminobenzoic acid. And the microorganisms that this drug class targets require para-aminobenzoic acid to form dihydrofolic acid. And then dihydrofolic acid is used as a building block for the organism's nucleic acids. So what a sulfonamide does is essentially mimic para-aminobenzoic acid and sort of tricks the organism into recognizing it as such. So essentially it interrupts nucleic acid formation. In terms of spectrum, you'll note that it does have good coverage against Staph aureus, including some MRSA isolates, most notably, again, those community-associated MRSA isolates. And you'll see a host of other bugs here that we consider it for. First line for Stenotrophomonas multifilia has a good coverage against pneumocystis, and this used to be called pneumocystis carinii, so an opportunistic infection or PCP pneumonia, essentially. You'll see that it does have poor strep coverage against strep pyogenes, not good enterococcal coverage, no pseudomonal coverage, and no coverage against anaerobic bacteria. Again, some discussion on practical clinical issues. This one is probably one of the more significant INR elevators when it comes to drug interactions with warfarin. So if you see a patient who's started on TMP sulfa or on Bactrim, we can expect that INR to go up within a couple of days. So I would argue a warfarin monitoring plan should be in place for all of these folks to make sure that they're getting their INR checked more frequently on therapy and someone's able to adjust the warfarin. Then likewise, you should have a plan for when the antibiotic is stopped so that we don't, based on adjustments made while on antibiotic therapy, then leave these folks subtherapeutic by not readjusting their warfarin at the back end of therapy. There are some significant skin reactions that can occur with these drugs, most notably a rash. The rash can be just a basic antibiotic rash or allergy rash, but in some instances we can see Stevens-Johnson syndrome or toxic epidermal necrolysis. So when someone has a rash from TMP sulfa, it should be evaluated. Again, this class can cause patients to experience photosensitivity or increased sensitivity to sunlight, making them more prone to sunburn. Higher doses or prolonged courses are actually associated with leukopenia. So if you do have someone who is either baseline leukopenic or if you are anticipating a long course, checking a weekly CBC would make sense. Another thing that you may see if you're monitoring serum creatinine is patients on TMP sulfa can actually have an increased serum creatinine, which may or may not be acute renal failure. So the sulfamethoxazole itself can cause crystallization in the urine, which can cause renal damage. Those crystals can impact the kidney. In that case, you would be looking at more of an acute renal failure picture. However, the trimethoprim component actually blocks creatinine secretion, so that can cause an increased serum creatinine, which is not acute renal failure. What we want patients to do on these drugs is to be very well hydrated, so emphasizing adequate water intake and avoiding beverages that can be dehydrating. And finally, caution with this class in patients with severe G6PD deficiency, and if that's a pathophysiologic disease state that you're not familiar with, I would encourage you to look it up and review it. Essentially what this can do is trigger hemolysis in patients with G6PD deficiency, so we try to avoid these agents if we have a known patient with that deficiency. Okay, so the next two agents that we're going to talk about are indicated to treat lower urinary tract infections only. We can't use them for anything else. The reason being is they only are active or only achieve their concentrations in the lower urinary tract. So The most common one that you'll probably see is nitrofurantoin. And essentially how this one works is it's a ribosomal-based activity. Again, it inactivates bacterial ribosomal proteins. In terms of spectrum, we use it primarily for E. coli coverage in the urine. It covers some staph and some enterococcal isolates. We do have to avoid using this agent if creatinine clearance is less than 50, and that's because it doesn't allow for adequate delivery to the site of action. If we can't have this drug get to the urinary tract because of low creatinine clearance or low renal function, it will be less effective. This one again has the caution in patients with severe G6PD deficiency as well. Another agent that is a little more expensive but does have an advantage of being a single dose for your patients whom you're worried about adherence is fosfomycin. It's a derivative actually of phosphoric acid, and it has a very similar spectrum to nitrofurantoin, can only be used in those lower urinary tract infections, can be used as a single dose for uncomplicated UTI and repeated doses for complicated UTI. Shifting now to an agent that has a primary workhorse role to treat anaerobes, and that's metronidazole. Many of the agents that we've talked about in our stoplight formation, you've noted anaerobes being in the poor or the red column, and metronidazole you'll see has good anaerobic coverage against obligate anaerobes. And an obligate anaerobe is that which can only exist in the absence of oxygen. So you'll see that mouth anaerobes are listed as having poor coverage, and that's because those bugs tend to be facultative anaerobes. It makes sense, and facultative meaning it can survive in the presence or absence of oxygen. And it makes sense that they'd be located in the mouth, right? Because you're breathing in and they're going to have oxygen exposure. So kind of the old school rule of thumb with metronidazole was we use it for anaerobic infections below the belt, so to speak. So you'll see it for GI type infections, abscesses, things of that nature where we would think of our obligate anaerobes. It also has some spectrum of covering protozoal infections, so for your travelers that come back, as well as bacterial vaginosis like with trichomonas, it has good coverage for those agents as well. In terms of its basic mechanism, it enters the cell wall and disrupts DNA synthesis. So this is a DNA synthesis inhibitor. There are a few notable practical issues with metronidazole that you should know in order to educate your patients. Notably, the one that people are counseled on the most, and you've probably heard about it, is a disulfiram reaction that patients may experience if they drink alcohol while they are taking metronidazole. I typically tell people to avoid alcohol while they're on their therapy as well as a couple of days following therapy, just to let the drug clear. What they'll experience is potentially a severe nausea and vomiting reaction. And really, it's not everybody. So I've had plenty of patients who have had a drink while they're taking their metronidazole and they haven't experienced anything related to a disulfiram reaction. But it can be pretty significant and pretty violent. So if especially your patient is on a short course of metronidazole, abstinence from alcohol is probably the best advice you can give. Again, you'll see that there's the potential to cause an elevated INR in patients who are on warfarin, so taking into account warfarin management and being in touch with the service who's in charge of that is important. If you do have patients who are on prolonged courses, so longer than 4 weeks, they can experience some neuropathies from it. So that's why you typically don't see this agent used for more than about a month at a time. Patients can also complain of sort of a bad metallic taste in their mouth. That's normal and should go away with therapy. And again, with more prolonged courses, you may see leukopenia and thrombocytopenia. So that, along with the neuropathies, are sort of the reason why this is an agent that we typically use for less than 4 weeks. Okay, shifting now to clindamycin. I grouped this after metronidazole because in this lecture it's kind of the follow-up to metronidazole's rule of thumb of covering obligate anaerobes below the belt. Clindamycin is another agent that has anaerobic coverage. However, it typically can also be used to cover those facultative type anaerobes. So we say that clindamycin can be used for anaerobic infections above the belt. So some that may be more facultative can be impacted by clindamycin. So you see the spectrum of activity here, and as far as the sometimes column goes, I would definitely want sensitivities back before relying on clindamycin to treat these agents. It's sort of a rule of thumb for the yellow column in all of these. If we have documented evidence for susceptibility, then we're more comfortable with using it if it's in the sometimes column. In terms of adverse drug effects from clindamycin, probably one of the most notable is the diarrhea associated with it, which can be severe and can lead to colitis. So this was one of the first antibiotics that has been associated with causing Clostridium difficile infections. And I haven't mentioned Clostridium difficile in the context of other antimicrobials in these two lectures because essentially now we know almost any microbial agent, antimicrobial agent with broad spectrum can lead to Clostridium difficile infection. But clindamycin especially, because of its target, its good anaerobic coverage, etc., that can be a big offender. So most patients who take this drug orally will experience pretty significant GI effects, and therefore it's often not first line for that reason. Now we're going to discuss the gram-positive agents listed here on this slide. And when I think of these agents, I typically think of using them to treat a resistant infection. So something like methicillin-resistant Staph aureus or vancomycin-resistant enterococci. However, we may also see these used in those patients who do have true severe IgE-mediated allergies to other antibiotics, especially the beta-lactams. You may see patients on vancomycin to treat susceptible gram-positive infections if that patient has an allergy. So let's walk through the stoplight for these agents here. You can see I have them listed for you across the top. I want to point out they're not all in the same drug class, so please don't confuse that as such. But since they're all used for similar indications, I grouped them together for you. So vancomycin, daptomycin, and the oxazolidinones, linezolid and tadalafil, can all be used to treat staphylococcal infections and streptococcal infections. However, I'd say that the one infection in that top group where you see them used most often is the MRSA classification. So if we have that resistant staph, we're going to go to these agents. If we have MSSA and someone with a beta-lactam allergy, you may see it used. Rarely, if ever, will you see these used to treat streptococcal infections, again, unless the patient has a drug allergy. In terms of enterococcal isolates, that's what the E stands for in this bottom row. Vancomycin can be used to treat enterococcus when we know that it's vancomycin susceptible. Daptomycin is a possibility to use against enterococcus that is vancomycin susceptible or resistant. However, it's a less robust drug against enterococcal isolates than it is against staph. So you may see it combined with something if we're using it to treat enterococcal infections. Not always the case, because sometimes it's still the best that we have in our limited arsenal against resistant infections. And then linezolid and tadalafil are indicated for treating vancomycin susceptible and vancomycin resistant enterococci. You may see them used as oral options for this indication because of those listed here, those are the only two that have oral options available. Just pointing out a few key bullet points on the bottom of the slide. Vancomycin, we do dose using pharmacokinetics. We take serum levels and measure it and dose adjust based off of that and target ranges by indication. And the primary toxicity with vancomycin is nephrotoxicity. So we want to watch that patient's serum creatinine and urine output as well. With daptomycin, CPK monitoring is recommended for patients who are going to be on probably more than a week of therapy. We do see CPK elevations in some patients taking daptomycin. It's not always correlated with myalgias or rhabdomyolysis, and we're more likely to see it in patients with renal insufficiency on high daptomycin doses and those who are on other agents such as the statins that can elevate CPK. Daptomycin should be avoided for treating pneumonias because it's inactivated by pulmonary surfactant in the lung, so we don't get good interstitial lung concentrations for daptomycin. And then as far as a couple of toxicities to point out with the oxazolidinones, thrombocytopenia is one of the primary toxicities, with linezolid showing more frequency of thrombocytopenia or a higher rate compared to tadalafil. And there's a potential for peripheral neuropathies as well. Typically, we see this with more prolonged courses, so 2 weeks or greater. Okay, so I'm going to shift, since we talked a little bit about the practical clinical issues with vancomycin and daptomycin at the bottom of the previous slide, the oxazolidinones, or tadalafil and linezolid, some of the practical clinical issues with those. One that's kind of interesting is when linezolid first came to market, we knew that it was a monoamine oxidase inhibitor, and there are drugs out there being used in the psych world in terms of treating some of the older antipsychotics like phenelzine and isocarboxazid. Really not commonly used anymore due to some of the dirtiness of their toxicities, as well as better newer agents that are available. And there are some other agents out there too used to treat Parkinson's disease that are targeted more towards the MAOB. So this is a drug interaction that could potentially occur, and really we should avoid using the oxazolidinones in any patient who is on one of these or within 2 weeks of taking it. What can happen there is essentially a acute hypertension crisis, similar to why we recommend avoiding concurrent SSRI therapy. So things like things like paroxetine, fluoxetine, etc. are antidepressant agents, a very widely used class for depression. And unless a patient on an SSRI can be actively monitored, we tend to avoid this combination. So for our hospitalized patients, we may go ahead and do it just because we can monitor blood pressures very frequently, or if they're going to a nursing home where they can do active blood pressure monitoring, it's potentially a bit more safe, but still, it's a definite risk. And if you can hold the SSRI while they're on the linezolid therapy, that's probably the right thing to do. Tadalafil has less data associated with it because it's the newer of the two agents. Linezolid's been around longer. In vitro, it's also an MAOI inhibitor. In their mouse models, they did not see any significant signals. However, they also excluded patients on therapies with MAO activity from their trials. We don't have great data to kind of back what to do with tadalafil. Another thing that you'll see noted with linezolid and tadalafil is the potential need for a low tyramine diet. I think this is a little bit of an overkill, and again, it has to do with that potential MAO inhibition. I think having perspective when discussing this with patients is very important. So for linezolid, the labeling recommends less than 100 milligrams of tyramine a day. Tadalafil is 325 milligrams of tyramine a day. So you can see from this chart that I made for you, essentially, you would have to have 4 liters of red wine in a day, 100 milliliters of soy sauce, potentially some aged cheeses, so that's, right around a little over 2 ounces of cheese. That would be potentially possible. But the rest of these, 300 kilograms of sauerkraut, even being in Wisconsin, I think that's not going to happen. So again, while that's listed there, the odds that patients are actually going to get enough tyramine in a normal American diet to cause a problem is slim to none. The last couple that I want to talk about are the lipoglycopeptides, and these agents are IV only and have gram-positive activity only. You may actually see them used in the outpatient setting, likely more there than the inpatient setting because they are single or two-dose regimens. So dalbavancin and oritavancin are the two that we'll focus on because they have more of the novel long half-life. Telavancin is available, but that's still dosed daily. With dalbavancin, the half-life's about 9 to 12 days. With oritavancin, even longer, about 2 weeks. To dose dalbavancin, you can give it one of two ways. It was originally brought to market by giving a single 1 gram dose, followed by a 500 milligram dose a week later, essentially. It was then subsequently approved to be given as a 1500 milligram single dose on day 1 only. With oritavancin, it's approved as a single dose as well. The one thing to note with it in terms of potential interactions is that it does cause an interference with the APTT lab assay. So this isn't that it's anticoagulating the patient, but it makes the APTT lab assay not be a reliable indicator of what the patient's actual APTT is. So for that reason, IV heparin is contraindicated because we can't adequately monitor it if someone is on oritavancin therapy. Shifting now to aminoglycosides, again, more likely to be seen inpatient and primarily workhorses for gram-negative infections. You can see that, again, these are dosed using pharmacokinetics and serum levels with the primary toxicities of nephrotoxicity and ototoxicity. This is included for you here just sort of as a sake of completeness slide so that you can see that most of our coverage is going to be targeted for using these in gram-negative infections, but I'm not going to assess you in detail on the quizzes and exams when it comes to aminoglycosides. Likewise, you won't be tested on polymyxin B and colistin, but I wanted to raise them here just because we are seeing these older drugs come back and have to be used for multi-drug resistant gram-negative organisms. The greatest risk here is nephrotoxicity. However, we can see some neurotoxicity. Patients can become confused or have balance issues. Again, noting that we use these only when we're facing ugly multi-drug resistant gram-negative infections because the toxicities are so significant. You may also see these used inhaled as second agents in patients who have lung infections with one of these multi-drug resistant organisms as well. So in summary, it's important to have that foundational knowledge of antimicrobial spectra and their limitations. And again, remembering that your local resistance patterns are very important and getting to know those based on antibiograms where you are, as well as establishing relationships with health departments and local laboratories. Using reference guides like the Sanford Guide, Hopkins Guide, or others can be helpful for you as well. So I'd like to thank you for your attention today, and if you have any questions, please reach out.